Good afternoon, everyone. And on behalf of the Office of Community Engagement here at VCU Massey Comprehensive Cancer Center, I would like to welcome you to this month's Massey Community Cancer Forum. My name is Jarrell with one R and two L's, and it is the highlight of my day to serve as your MC as we get connected. Every time we gather, we're reminded of the power of community, the power of showing up, learning together, and supporting one another in ways that strengthen our collective health. This month, we're focusing on colorectal cancer awareness, a topic that touches far more families than we may realize. But the good news is that colorectal cancer is one of the most preventable cancers we face. With regular screening, early detection, and informed choices, we can save lives, our own and those of the people we care about. Today is about understanding, breaking down the barriers, and creating space for honest conversation. Whether you're here for yourself, for a loved one, or simply to learn your presence matters, you help make this forum a place where information becomes empowerment and where community becomes action. Our agenda today is simple, and then I might want to add too, we do still have the pre-form survey link. So if you say, I just said it and I took it away, please feel free to scan that and complete that for us. So our agenda today is simple and designed with you in mind. We'll begin with some shared understanding, move into our expert insights, open the floor for questions, and then end with ways we can take knowledge back into our communities. Now, we know conversations about cancer can bring up emotions, questions, and memories. I want you to know that this is a supportive space. We learn together, and no question is too small. To ground us, before we even really get into the speaker, I want to cover a few key things to know about colorectal cancer. So first, I want you to know that colorectal cancer is one of the most preventable cancers. Screening can find it early, or even prevent it by removing polyps before they become cancer. Most people should begin screening at age 45, but some may need to start earlier based on family health history or risk factors. To help us understand this more deeply, we're honored to have today's expert speaker here with us. So our speaker today is Dr. Kim Rhodes, the Associate Director of Community Outreach and Engagement here at the VCU Massey Comprehensive Cancer Center and a professor of colorectal surgery in the VCU School of Medicine. Dr. Rhodes joins us from the University of California, San Francisco, where she most recently served as the Associate Director of Community Outreach and Engagement at the Helen Diller Family Comprehensive Cancer Center. Before that, she founded the Community Outreach and Engagement Program at the Stanford Cancer Institute, where her work helped to set the national standard for how cancer centers partner with communities. And then Dr. Rhodes' expertise spans the full cancer continuum, from basic science and cancer risk reduction to clinical care and colorectal surgery. She also brings extensive training in community organizing and community-based participatory research, grounding her work in authentic partnership and shared leadership. Her leadership in community outreach and engagement is nationally recognized. And as our leader even said, her work at Stanford USC has set a benchmark across the country that many cancer centers aspire to reach. We are honored to have her here at Massey, and please join me in welcoming Dr. Kim Rhodes.
Thank you, Jarrell. That was way over the top. I thank you for the invitation to kind of kick us off in thinking about colorectal cancer. And I appreciate everybody who's on the call. And I look forward to your questions and this discussion. This is obviously a passion of mine. I picked colorectal as a specialty as a surgeon because it is preventable, treatable, and beatable. This is one where we really can win. So, so with that, I'm going to jump into the slides. I'm going to give you a little bit of, what is the distribution of colorectal cancer, what's happening in Virginia, specifically around colorectal cancer. Then I'll give a little bit of an anatomy lesson so we know what and where we're talking about. And then we'll go into risk factors, how to reduce your risk, things like that. And then we'll talk a bit about screening, and then I have a call to action at the end. All right. So with that, we'll start off just by reminding everybody, because you probably heard this mantra before, but colorectal cancer is the third most common cancer in men and women when you combine them and look at them together. And unfortunately, despite the fact that it is preventable, treatable, and beatable, it is the second most common cause of cancer-related deaths for all ages. Now, when we look by the numbers, yes, big numbers, because it's a very prevalent and common cancer. But the thing that I want to continue to emphasize is that there are over 1 million Americans who are living with us as survivors right now. So it is 100%, it is beatable. And so want people to really come away from this talk understanding that you can survive colorectal cancers. We just got to get in there as early as possible. So these are some slides that I lifted off of a presentation from Dr. Jackie at BDH, who shared some of the colorectal cancer distribution in Virginia. So what you'll see here is that colorectal cancer incidence by race and ethnicity, you're going to see some typical disparities that we are very used to. The blue bar is all populations, but then it's broken out by color. The black box is white population, gray box is black population, yellow box is Asian, blue is Native American, and red is Hispanic. And nationally, the incidence of colorectal cancer is 36 and a little bit over 36 cases per 100,000 persons. And what you'll see here is for women in the Commonwealth, the incidence is lower than the national rate, but for men, it's actually higher. And I want to highlight for African American men, it's significantly higher, as well as for Native American men, significantly higher. So these are populations we need to pay attention to. In terms of mortality, you see the distribution of disparities that we saw in incidence reflect themselves again in mortality, with high rates of mortality for Black women as well as for Black men. And then also of note for Native American men, the rates of mortality, of death, are higher. This is a curable disease, everybody. So let's keep that in mind. Also of note and big in the news right now is the incidence of colorectal cancer in persons under the age of 50. So these are data from Cancer, a journal for clinicians. And what we're looking at here in these lines are the different locations of the colorectal cancers, and I'll show you the anatomy in a second. But I want to really put your attention on the orange line. Okay, so keep your eyes on the orange line for all of these. Now, this is all ages. This first box, top left, top right is ages 20 to 49 years of age. Bottom left, 50 to 64 years of age. Bottom right, 65 years of age. And what I want to point out is in all of these, if you watch this rectum and rectosigmoid junction, which is the end of the line, that yellow line, if you watch this, or orange yellow line, whatever color it is for you, you see it is the only line that is going up in all ages. But importantly, it's going up a lot in 20 to 49-year-olds. 20 to 49-year-olds. So this is before screening, everybody. So this is something that's happening, as we say, ecologically. So it's kind of happening all over the world. We don't totally know why. And in fact, mortality is changing as well. And now colorectal cancer is the top cause of cancer death in young people. So there's going to be a couple lessons here, not just about screening, but about paying attention to your body, listening to your body, being insistent and advocating when something is going pear-shaped, as I like to say. When things are going sideways, we need to press hard and make sure we get answers. Okay, so anatomically, what are we talking about here? The colon and rectum, I think people kind of think of the whole thing as one big old thing. They have different functions, okay? The colon is the bulk of the large intestine. It's about 5 feet or more. It's all packaged up inside the abdomen. And it runs from the right side of the body where you see the appendix here, goes up the right side of the body, across the top of the abdomen, and then down the left side of the body. And then after it makes this little turn here, that's the end of the colon. So that part's the colon. The 16 centimeters or so at the end of the line is the rectum. The colon's job is just to absorb water. The rectum's job, and then move the stool down into the rectum. And then the rectum's job is to hold it until you're ready, near a bathroom, got everything in place to get to what you need to do. Okay, so what is colorectal cancer? So it typically starts as a polyp that grows from the inside of the colon and then grows through the colon wall or the rectal wall. So a polyp is an abnormal growth of tissue And if they're left to kind of to their own devices, they can turn into cancer over time. We think theoretically it takes about 10 years to go from just a polyp that doesn't have any malignancy, no evidence of cancer, to becoming something that's got some cancerous cells that are willing to cross barriers and invade things, which is really what defines cancer. The stage of cancer depends on the depth of invasion through the colon wall. So I want to point you specifically to this graphic here in the right lower corner. So what you're looking at is a polyp growth that we're calling a stage 0. You can see that there are multiple layers to this bowel wall here. So there's this light pink layer, and then there's kind of this yellow layer, and then another outer pink layer. So as the growth starts invading from the inside of the colon to the outside of the colon, this is where the stages start to advance. This little square that's inset is giving you a close-up visual of what's happening in each of these layers. So this part where the polyp starts is called the pink mucosa. That's like the stuff in your mouth. It lines from your mouth all the way down to the end of the line. In the submucosa, which is this white layer, this is where you're going to find the lymphatic channels and blood vessels. So again, as a cancer starting to grow from this mucosa into this area where there are lymph vessels and blood vessels, that's where the cells are going to start to find an escape. As they grow through that, you get more progress in terms of stage. What this graphic is showing you right here is that for stage 0, stage 1, and stage 2, there's invasion, at least in stage 1 and stage 2, into the bowel wall, but there's no involvement of these lymph nodes. These are the little green things here. And you see these are white on the inside. When you get to stage 3, by definition, that means that lymph nodes are involved. You see the little red dots here inside of the lymph nodes in stage 3, as well as in stage 4. But in stage 4, not only do you have lymph nodes involvement, but you have tumor cells trying to escape to go to other places, most commonly the liver. Now, the reason that's important, we're going to come back to, because the stage at the time of diagnosis has a big impact on survival. So I want to talk briefly just about the risk factors that you actually can change. So they're mutable, right? You have some control here. You can reduce your risk of developing colorectal cancer by maintaining a healthy weight. I know everybody's constantly paying attention to that and struggling with that. But that is something that you can do to help your overall well-being, but it also reduces colorectal cancer risk. Sedentary lifestyle, kind of sitting around, not exercising, not getting movement. And I'm not saying you have to go hard and do cardio. You could just go for a walk every day, right? We need to keep our bodies moving. That will decrease the risk of developing a colorectal cancer. And then we want to avoid, just in terms of general healthy lifestyle, avoid diets that are heavy in red meats or processed meats, and reduce the intake of processed foods in general. And then smoking and alcohol, of course, are associated with just about every cancer in the book. So we want to reduce those consumption of those products in order to reduce our risk. Now, there's some things that you can't change, okay? The risk of colorectal cancer, at least historically, has increased with age. We now know that young people are getting it. So this is something that we're going to have to dig into. But you can't stop the clock. So you're going to age, and that is going to increase risk over time. Having a personal history of polyps or previous cancer also increases the risk. We talked about adenomas, or those polyps that can, over time, turn into cancer. Personal history of inflammatory bowel disease, so Crohn's disease and ulcerative colitis, that chronic inflammation, that turning over of the intestinal mucosa, can contribute to the development of cancer, because as the cells are turning over, they're making more of themselves. They're making DNA mistakes potentially and turning into something that is not so nice, not benign, but actually malignant. So folks with inflammatory bowel disease are already usually on some kind of regimen of screening on an annual basis, of surveillance, to make sure that no cancers are growing within that inflammatory process. And then having a family history of colon cancer or polyps can increase the risk. Now, I want to emphasize that most colorectal cancers are not familial in nature. And we are going to talk about family history, not this month, but I think we may hit those high points next month. But just know that uh, that looking through your family history is important. It's important to know, but it doesn't, if nobody has had colorectal cancer in your family, it doesn't mean you're not going to get it. You'll still have to follow these general guidance about reducing risk and sticking with proper screening protocols. Okay, so what are some of the signs and symptoms of colorectal cancer? A change in bowel habits. Now, that doesn't mean, well, yesterday I had, loose stool, so now I must have colorectal cancer. It really is a change in bowel habits that persists over time. And so what I'm talking about is somebody who goes to moves their bowels maybe once a day. Suddenly you're moving your bowels like 2 or 3 times a day, and that persists over time, or the texture quality of it changes. So that can include that you're seeing globs of mucus in it, or you're seeing bits of blood in there. If you are seeing any of that, you need to seek answers as quickly as possible. And especially if you're young, you need to be persistent. As a colorectal surgeon, everybody got sent to me who had rectal bleedings like, this is a hemorrhoid. It's not always a hemorrhoid. So somebody actually needs to look. And if they don't see a hemorrhoid, then you need further evaluation. The other things that you might see are unexplained weight loss, abdominal discomfort. You might be feeling tired. Cancer is a catabolic process. It is it's like turned on all the time. It is feeding itself. It is eating all the time. So that can make you tired and exhausted. But importantly, sometimes there are no symptoms at all. And that's really important because screening is for people who are not having symptoms, right? If you're having symptoms, then we need a diagnosis. But screening is for people who do not have symptoms at all. So often that is that, especially with right-sided cancers, sometimes there will be no symptoms until the tumor is very large. Okay, so screening is important, therefore. The screening age has been lowered to 45. I am 56 and I got screened at 50 because that's when the screening guidelines told me I should get screened. But as we're seeing this uptick in people who are getting colorectal cancers at younger ages, we're now wanting people to go ahead and get screened at 45 if you are of average risk. And average risk I have down here in the tiny print. It means no family history, no personal history of colorectal cancer, no personal history of polyps or inflammatory bowel disease. So if you have any of those risks, then you're going to need to be screened by a different method. So fecal immunohistochemical tests, or FIT, should be done yearly. This detects blood that you can't see with your eyes, and it's important that it's human blood. So I heard somebody talking about a hemocult yesterday. This is something we used to do when I was training, when I was a medical student and a resident. We would do a rectal exam on everybody, put it on a card, and look for blood. The problem with those old cards with the hemocult is it picks up any kind of blood. So if you had a big steak last night, it's going to pick that up, right? And then we will erroneously think that you're bleeding. So the new FIT tests that we're using and Cologuard and things like that are really looking for human evidence of human blood being shed in the stool. If the test is positive, it must be followed up by colonoscopy because we need to see the entire colon in order to figure out where this blood is coming from. And obviously, somebody needs to examine the anus and see if there are hemorrhoids or a fissure. But more than likely, those are not nice substitutes for a positive FIT test. That has to be followed by a colonoscopy. We also now have blood-based testing for colorectal cancer, which has been approved by the FDA in 2024. That product is called Guardant Shield. Some of you may have heard of it because it's also being used in the Vanguard study. This is because even though the FDA has approved it for colorectal cancer screening, they realized that they were getting and finding all kinds of other signal when they were running the test for colorectal cancer. And so now that's being tested in the Vanguard study to look for other types of cancers. But Shield is FDA approved for colorectal cancer. I think the thing to know about it is that what it's detecting is cancer. And if you think about what we want to detect in a screening process for prevention purposes, we want to detect polyps. So if we just quickly look at the percent of polyps, the sensitivity for detecting polyps on the Shield test versus the FIT test or Cologuard, which is down here, you can see that Shield, the blood test, not that great for polyps. It's good for cancer, not great for polyps. So that's just something to keep in mind. But obviously, some people prefer it because then they don't have to actually handle their waste in order to get screened. All right. So what happens if the test is positive? So if any of the tests, either blood-based or FIT, and by the way, the blood-based test is recommended to be repeated every 3 years. But again, it just got FDA approval in 2024. So I think we don't have the long-term data to, um, uh, so it may change. Let me just say that. Everything in medicine and healthcare can change because we have people kind of going through these processes over time. We accumulate more data and more understanding, so things may change. But right now, it's recommended every 3 years or so. Okay, so if either of those tests are positive, you're going to be recommended to undergo colonoscopy, and this is critically important. Your screening is not complete if you have a positive stool-based test and you don't get a colonoscopy. You have not been screened. So with a colonoscopy, for those who are familiar with people who have gone through this before, you drink this 4 gallons of salt water that make you really empty the colon, and it's critically important because when we're looking in the colon and rectum with the colonoscope with the camera, we actually need to see the mucosa, and that's what's being shown here. So this is the view on colonoscopy. The operator is looking at that on a television screen, and when a polyp is found, then a snare can be deployed through the camera. And so it's like a little lasso, but it's got heat. So you put the lasso around the polyp, you heat that up, and then the polyp is removed. That is actually prevention if the polyp has not yet turned into cancer. So here's I'm showing you from a side view. Again, this is the inside of the intestine. This is the outside out here. The polyps are developing in the mucosa. This is a large one. This one's got dysplasia, which means it's on its way to cancer. This one is truly cancer because it's broken through the layer of the mucosa and gotten into that special layer. Remember where I told you where the blood vessels and the lymph tissues are. And then this one is just frankly cancer. This one, as you can see, still has some polypoid tissue, so it's still polyp. This one is fully cancer. So if we remove these during colonoscopy at this stage, when it's just severe dysplasia, that's going to be prevention. Or if we remove them anywhere before that, that's prevention, okay? Early detection would be to catch it before it starts breaking through all of these other layers and really getting into the lymph nodes and trying to move itself to the liver or other locations. So again, you would start this process at age 45. You can skip the stool-based test and go straight to colonoscopy. But if you are at high risk or more than average risk, you should start with colonoscopy. You are not eligible for stool-based testing. Now, if you have a family history, you need to subtract 10 years from the age at which the youngest person in your family was diagnosed, and that's when you would start screening. So if someone in my family was diagnosed at 45, I need to start my screening at 35. Okay, colonoscopy, once you're done with that, you get to skip the screening. You don't have to do the stool-based tests in between. You get to go for 10 years. Because remember, we sort of think that it takes a polyp about 10 years to become a cancer. That's where that 10-year mark came from. So just as I mentioned in the run-up, the earlier it's detected, the higher the survivability. So I want to just really focus in on stage one. So if we detect a cancer at stage one, before it's really broken through, before it's involving any of the lymph nodes, it's almost 100% 5-year survival. And this is just for 5 years. So people are living long beyond 5 years when these cancers are detected early. And again, you can just sort of see the trend over time of how the survival rate drops down. Now, this slide is from several years ago, so my sense is that we probably are doing better on stage 4 disease because we have more targeted chemotherapies. That's when you need to be thinking about chemotherapy that are probably giving us a better survival rate. But I really wanted to make the point here that it is about the difference in stage as it correlates to the optimal 5-year survival rate. So you really can, most people really can survive a long time with stage 1 and 2 disease, and still with stage 3 as well as stage 4 disease. The one thing I wanted to say, because I don't think I have it on here, is I wanted people to understand chemotherapy and why we use chemotherapy. So when we give chemotherapy, we typically give it so that it gets into your bloodstream. That means it's treating your entire body. Why do we do that? We do that when we know that the tumor has tried to make an escape, either to the lymph nodes or to another location. So stage 3 and stage 4, sometimes aggressive stage 2s, where we think we don't see that the lymph nodes look like they might be enlarged, but we're suspicious, then those patients might also get chemotherapy. So the idea behind chemo is it's whole body treatment, it's systemic, it's going to try to zap what's in these lymph nodes, it's trying to zap what's in the liver, as well as get rid of the bulky tumor that started the problem in the first place. So systemic therapy. Okay, so how are we doing on screening? So this is again from our friends at the Department of Health. You can see that what I'm showing you here is UDS data. So that reflects on people getting their screening done at FQHCs. Nationally, that rate of screening is about 40%. So our FQs, for those of you who are at FQs in the crowd today, give yourself a little pat on the back, but don't get too excited because we are higher than the national average, but we are still less than 50% of patients getting treated and taken care of primary care in FQHCs who are up to date with their screening. So there still is work to be done, but we're still a little bit ahead of the rest of the country. This data is based on what's called all payer claims data. So it's not necessarily about where the patient gets care. It's just that we have the records of what the insurance companies were paying for. So that gives us a greater sense of kind of a more of a statewide average of screening rate, and we're at about 50% of people in this all payer claims database. So that means mostly people who have some kind of insurance. We're at about 50% in terms of screening. However, as I was putting this presentation together, I came across one slide that made me very concerned, and I hope that you all will heed and work together with us for this call to action. The first thing is that we know that the age of screening lowering to 45 has only happened very recently. And so you can see that the rate of screening in that group of 46 to 50 is extremely low. Tons of work to do here because I just told you off the top that colorectal cancer is increasing in young people. And it is causing death in young people. So we need to be more aggressive. If there's somebody you know who's 45 who hasn't been screened, you can start the conversation now. Have you been screened? Are you thinking about getting screened? We can help you get screened. So we need to push on this because this is the group that is really suffering the burden of this preventable, treatable, and beatable disease. Now, this is the map that gave me pause and made me feel like we've got a lot of work to do. So what I'm showing you here is in the highlight is the catchment area for Massey Comprehensive Cancer Center. This little star represents Richmond, and that is where the cancer center is. This is a heat map, and the heat is going from light blue to purple and fuchsia and bright pink. So with increasing percent of what we call late stage diagnosis. And that's being defined as regional or distant spread. Regional means the lymph nodes, that's stage 3, remember. Distant means it's trying to head to the liver and other places. That's stage 4. The colors that we would love to see are this kind of lovely bright aqua, but instead what we're seeing is a lot of purple, fuchsia, and pink. That means that folks are presenting with late stage at the time of diagnosis all across the Commonwealth in our catchment area. I wanted to focus here just for the purposes of this audience. But these kinds of maps can also be generated on the VDH website, so you can see the rest of the state if we're not covering the locality where you're from. But again, we have a ton of work to do because I'm seeing too much fuchsia and too much pink here. With that, I want to let you all know that we have produced our new colorectal cancer awareness screening materials. And what you'll find on these cards is people who you may know, and some of these folks may be in the audience currently. I hope they are. So Miss Aileen, Deborah, and our own Sharmika here from Massey are examples of colorectal cancer being prevented, being treated, and being beaten. So these are real stories. It's a real assertion. It's truly preventable, treatable, and beatable. This little QR code, which you're going to find on the front, is going to allow you to check, am I eligible for screening, or is someone else eligible for screening? So you can fill this out with someone you love who may not be facile with the QR code. If somebody could drop the bit.ly link in the chat, that would be great, because you can click on it now, walk through the questions. When you answer them, it's going to tell you, it's going to spit back to you, yes, you're eligible, or no, you're not. If you're not eligible, it's going to tell you why you're not eligible. And then it's going to allow you to sign up to get help from our COE staff to help you get to a screening somewhere in the Commonwealth. And we're really trying to help you get to, if you're far away from Massey and from the mothership, we're trying to help you get into the locations that are near you, because we want everybody to get screened. It's not a commercial for Massey, except for the fact that we care that everybody in the Commonwealth gets screened, and that we can turn that fuchsia and purple map back to light blue. On the back of these cards, you're going to find the frequently asked questions about colorectal cancer. Is going to cover a lot of what you just heard me talk about. And then on the very back, we have our Massey resources QR code, where we put everything all in one place. So we hope that you will engage with us and request these cards and hand them out, because the truth is, wherever this QR code goes, there's an opportunity for somebody to help us prevent, treat, and beat colorectal cancer. So just wanted to wet your whistle and let you know that it can run in families. About 1 in 300 people have what's called Lynch syndrome, or hereditary. The H is for hereditary non-polyposis colon cancer. I've just listed a few features here. Typically the cancers run in families, and you will see other types of cancers associated. So when you see this combination, oh, somebody had gastric, somebody else had uterine, somebody else had small bowel or bladder, you need to start thinking, okay, do we have one of these syndromes? We're going to learn a lot more about this next month. So please stay tuned. And with that, I thank you all for your attention, and excited to have a little bit of discussion and take questions.
Yay, that was amazing. That was amazing. Thank you so much for sharing your time with us, Dr. Rose. So I want you to know the chat was on fire the whole time you were talking. So we have a jam-packed Q&A. So usually, we'll stop and we'll let people come and ask the questions themselves, but I know we're running short on time. So I'm going to ask them first, and then we'll circle back to some that were already answered, but I'm telling you, the community loved it. All right. So first question from Carmen. Was why Hampton Roads are one of the hot spots for colorectal cancer in the United States? What about the prevalence in the Latino community?
The prevalence in the Latino community, I can pop back up one of the slides. You can actually see that the prevalence in what I was showing you for the state is not actually broken down by race. But if we go back to this slide, let's see here, you can see that the rates for what are labeled as Hispanics, call that Latine for now, is relatively lower than all other groups. Now, when we go to mortality, and then again, just remember this is just for the state of Virginia, the mortality rates are also relatively lower. Now I guess that might be somewhat surprising, but important to note, and also to ask a question about, why is it lower, right? Should we be asking that question? Should we be doing a study across the state to understand, like compare risk factors, for example, in different populations, to compare, access to care and quality of care in different populations, right? These are some of the explanations that may be at play. As far as the Hampton Roads area, if I'm not mistaken, that is an area that includes like a naval shipyard, And when I think of the shipyard, I'm thinking about heavy metals, I'm thinking about
Yes.
other environmental exposures, and I'm not promising that that's the answer, but I'm asking a question, right? Is that something that we need to be looking into?
Right. Mhm. And then I think this is a follow-up question, kind of in the same vein. This is from Nancy Valencia. And she was talking about one of the graphs that you was just on. She said one of the graphs shows that the Hispanic mortality rate is lower than that of the overall population. Are there known protective factors that may contribute to this pattern, or could this difference be explained by underreporting or data limitations?
So I would say in the time space that we're living in right now, underreporting and data limitations, 100% could be part of the problem, right? Everybody's not trying to pop up and say, "Hey, count me," right now. These are data from 2022, because the cancer data always lag. But again, I do think it's important that we think about, should we be doing a study to gather by survey, assess the risk factors in the different populations in our catchment area and make a comparison to see if it is about reducing risk or if it is indeed a data error or undercounting of those populations. The other thing I'm just going to say is that we do have what is in the published literature called the Hispanic mortality paradox. And what that is effectively saying is this is a group of non-white peoples, potentially of immigrants. And so in our country, usually if you are non-white, then the outcomes are not as good. But here we have a group where the outcomes look like they're better. One question that has been advanced is, or one thing that has been observed is that once people have been here for a number of generations, their outcomes start to look like American outcomes. And with the GI tract, you can really make a quick correlation between like what you put in it, right, and how that's interacting with your body. So if you're coming here from another country, you may have a different way of eating, different types of foods that are highlighted. The Western diet, with our like our red meat and lots of carbs and all that good, yummy stuff. Um, um, once people what they call acculturate or start eating like the place where they live, then you start to see that the outcomes can become quite similar. So the question is this a heavily like new immigrant population in Virginia, right, that has not yet adopted sort of Western diet? I don't know the answer to that for Virginia, but those are the kind of the concepts and frameworks that are out there that could help us start to ask some questions or target our questions to figure out if this is an issue of immigrants not yet acculturated or if it is just in general some reduction in risk through lifestyle behaviors.
That was an amazing answer. Thank you. That was very informative. So I saw a couple of questions about young people. So if you guys don't mind to ask a question about young people, I'm going to combine them together. So the people really want to know, Dr. Rose, now, why is CRC on the rise in young people and why haven't the screening recommendations changed to reflect that?
So much to say here. Okay, so paper in 2011, way back in the Wayback Machine, showed that Black men are getting polyps, more polyps earlier and than everybody else. And at the time, I was at Stanford, and I actually got into a bickering match with Otis Brawley, who some of you may know, because what I asked him is why aren't our screening guidelines tailored for actually how people experience the disease, right? So we may not lower it for everybody, but if Black men are getting polyps at 40, why are we not starting screening earlier in that population? And his answer was, oh, it's all registry data, so we don't really know what the reality is. I mean, most of these studies are from registry data. So, yeah, so that didn't go well. He was not happy with my question. But the reason I bring it up is because it's 2026, and it was only in like 2023 that the age got lowered,
Yes.
right? So when we're now seeing that that it's really advancing, and I believe one of our GI fellows sent me an article showing that the same number of cancers and in fact worse outcomes were happening in people 40 to 45, right? What I just think to myself is like, how long are we going to have to sit with that before we change the guidelines? Right? Because changing the guidelines requires studies of hundreds of thousands of people. Like there has to be a big study that shows us that you will save a life by starting to screen people under 45. And we just got the evidence that we have to move it to 45. So we don't yet have the evidence to move it to 40. I mean, the sad thing is, so in the meantime, people are dying, right?
Oh, that's the truth.
So it's a conundrum.
It is.
Yeah.
Thank you. That was actually interesting, especially for myself. Okay. And so now that we got a couple of young folks and stuff like that, I want to cover some because I see that we have the community really, really empowered. So folks want to know what they can do. So Mary Simmons asks, how can we get this information to family practices to provide this information on early prevention during annual checkups?
Yeah. Hmm, great
I want to
question.
pick your brain with this one. I said, I think that's a great one for you.
We
Yes.
we do have some collaborations. I know, Jarrell and Tiffany, Soli, Raja, and Emily are have been embedded in some of the FQHCs, and they're literally there to try to help people get screened. What we don't have yet there are these cards, which I feel like the cards travel, right? Because you can take the cards to another state. The guidelines are the same, right? So we need to get these QR codes or at least people's ability to interface with these QR codes and just be asking for themselves, like, am I eligible for screening? Because you know the workflow in the clinic, right? I've got 15 minutes if you're a return patient. I've got 30 minutes if you're a new patient. And there's a whole bunch of stuff I got to cover. And maybe I'm not covering that, but there's something more pressing, like blood pressure that could give you a stroke tomorrow, right? So I think we need to be creating materials and developing and listening to the community. What materials, what interventions will you interact with? That's what we need to be putting out there and pushing out there so that people can take ownership of coming into the appointment to say, I just did that QR code in the waiting room and I'm eligible for screening and I want to be screened.
Like that.
And for the young people who are having symptoms, keep pushing. And if you are not getting answers, please sign up to engage with us and the staff who are supporting people to get screened, to get things checked out. If you have any bleeding from your bottom, somebody has to look. And most primary care doctors not super duper comfortable with the anus. I happen to have been a pelvic floor person, so like real comfortable, but you need somebody to actually look down there. And there is a little tiny anoscope. It's real short. You're awake. It's not like a colonoscopy. They need to look. If they don't do an anoscopy and then they tell you, oh, it's just hemorrhoids, you need to keep pushing. And if you need our support, we'll help you.
Absolutely. All right. So it's 1:48. So I think we probably got time for one more question, Dr. Rose, and then we probably got to keep it rolling so we can get these people out of here. So, oh, this is so hard picking the last question. I'm trying to see what's something that we can do that's lasting for the people.
But we'll give
Um,
answers you'll send me whatever questions didn't get answered and we'll answer them and make sure everybody on the call gets that.
oh, if that's the case,
Yes.
then let me just
All
pick this
right.
one, then we can answer the rest of them then. So
All right.
Dana asks, also, do you think stress can be a contributing factor towards colorectal cancer? Because everyone's dealing with stress, and I think that again during this time, people are wondering what are the environmental factors, how they can mitigate their risks. So you think stress is a part of that?
Um, I think stress is a part of cancer in general. How it manifests itself, I don't have an answer for that. But I would say, when you're stressed, your cortisol goes up. That can worsen a whole bunch of other things that are, potential risk factors for poor survival. Are they directly risk factors for developing colorectal cancer? I don't think we actually have those answers. Um, but one thing I will caution us to pay attention to is the fact that this is going up everywhere means it's got to be in the food. And I feel like it's in the food. And I also just want to, and how our food is processed, right? And packaged in plastic. And how much plastic are we ingesting? And,
Yeah.
is that a factor? And the reason that I'm really like dogged on this is because You remember the slide I showed you with the orange line showing rectosigmoid cancers going up and rectal cancers. So when we say young people and we say colorectal, as a colorectal surgeon, I want to differentiate because the rectum's really magical. It does a lot of things. It's super smart. It's a very smart organ. These cancers are in the rectum. So that's the storage facility for the stool. And that's why I'm so dogged about asking the question, is it in our food, the way it's processed, the way it's packaged? Because these are not cancers that are distributed all over the colon. They are at the end of the line, which is storage. And whatever's in that stool is sitting next to the pink mucosa, making it inflamed, irritated, transforming it. We don't know. But I want us to also keep an eye on that the young ones are rectal and the end of the colon. It's not just generic colorectal cancers. So,
Amazing, amazing answer. So, you guys, the chat is still absolutely on fire. I love, love, love that. And I know I saw quite a few questions about hereditary cancers. I know you guys want the hereditary piece. Why we didn't cover that. If you were interested this month, you gotta come back for part 2 next month. Again, just dropping these links again. We have the link tree. If you're looking for us to support you at our event, we have something new that we're dropping for the first time, which is our event portal. So I know previously, before you kind of work with Massey, you might have reached out to an individual. You tried to say, who can I reach out to? Who do I get? We have one centralized place now. So if you are interested in having Massey at your event, or you want some of those materials that you saw today, I'm going to ask you scan that QR code or click the link in the chat so that you can make that happen. Now, if you're super, super volunteer, I mean for the super engaged that wanted to connect, we have an opportunity to volunteer with Massey. So we have our volunteer portal finally. You can scan that QR code or drop that link if you're interested in volunteering with Massey. We will have some trainings coming up, so please keep your eye out for that. If you were on the call before, we thank you for your service and we hope that you continue again this year. And if you were not able to access any of those links, or for any reason you have any extra questions or anything, we do have our contact information at the bottom with Engage Massey and the phone number. Dr. Rose, I know we dropped some loose stuff. Would you like to add something? Just want to make sure. I know you're excited. You worked really hard on this.
no, but I want to make sure that people are aware that we would love to come to your events and bring the opportunity. Are partnered with Hitting Cancer Below the Belt. I'm sure Mindy Conklin is in here. I can't see of the 160 people.
She is, and yeah, and her clinical coordinator. So
excellent. So we will be engaging with them to help people get screened, like I say, on the street. The entry into the health system is through the community instead of through the ER. We'd rather see you getting screened out at an event than see you in the ER getting diagnosed. So please engage with us around that. And these screeners, when you get this slide deck, share them with your loved ones. Get the young people involved. They love these QR codes. They could be doing surveys and then know who needs to get screened and then hold them accountable. I thought the survey said you need to be screened. Let's get you screened.
And then finally, we're going to announce the save the date for the next Community Cancer Forum. Again, it'll be a part 2. So this time we'll cover the hereditary piece of colorectal cancer. And that will happen March 24th, 2026 at the same time from 1 to 2 p.m. So please register. We have a lot of surprises for you. And for community organizations, if you're interested in having your events promoted, we're asking that you do submit those so we can get yours added to the ad section as well. And for watch parties, if you're interested, again, I'm asking, I would love to come and host for somebody's place. Please reach out to Engage Massey so we can get some more watch parties started. I want to thank you so much, everyone, for attending. Thank you, Dr. Rose, so much for coming and presenting and sharing such great knowledge. And for everybody, I'll catch you next time. Thanks for connecting.